Hello, everyone. Thank you for joining today's NCCN webinar on for patients. My name is Laura Hanish, and I am the moderator for today's webinar. So for those of you who are not familiar with NCCN, it stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading cancer centers across the United States, devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These resources are funding using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon. The NCCN webinars for patients complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. So this brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Lindsay Rhine. Dr. Rhine is Associate Professor of Medicine at Duke Cancer Institute. Following Dr. Rhine, we will hear from Meredith Moorman. Meredith is a hematological oncology clinical pharmacist at Duke Cancer Institute. Our third presenter today is Ruth Fine Revel, patient advocate and health science writer. Now I will turn it over to Dr. Rhine.
All right, can everybody hear me? Hopefully. Good afternoon. My name is Lindsay Rhine. I want to thank the NCCN for this opportunity to give this webinar. I've been so fortunate to be a part of the NCCN guidelines now. And so it's a wonderful opportunity to interact with patients and provide some info, answer some questions. And so what I'm going to do today is talk a little bit about the diagnosis, risk assessment, and some management options for patients with various MPNs. And I like to just give a little overview to start. So what are MPNs? When we think about MPNs, we generally think about the classical MPNs, which include polycythemia vera, essential thrombocytosis, and primary myelofibrosis, which is what we'll cover today. These are bone marrow disorders of hematopoietic stem cells, as you can see in the picture on the right there. And they are characterized by acquisition of three classic MPN driver mutations. So specific mutations that drive the development of these diseases and lead to, in general, an overproduction of blood cells within the bone marrow and then the peripheral blood. And you can see listed there the three mutations that we typically see, which are JAK2, MPL or MPL mutations, and then calreticulin mutations. And I think the important take-home point from this image is to say that these mutations lead to dysregulation of erythropoiesis, so blood production, and dysregulation of megakaryopoiesis, so that is platelet production. So problems in both of those types of blood cells. So I put this slide up next to share and have you think about the fact that MPNs really are characterized by chronic inflammation, and they share many features that are consistent and in line with chronic inflammatory disorders. So as patients come to clinic and talk about their symptoms, we see a lot of hallmarks of inflammation as presenting symptoms. So they're involved in the pathophysiology of the disease. Inflammation leads to some of the symptoms we see. It can increase the risk of thrombosis, which is an important complication for MPN patients. It can lead to disease progression, and it also increases risk of cardiovascular disease, which I think is an important point as we think about treatment options and what's right for each individual patient. So again, we think of MPNs as bone marrow disorders of stem cells. And I love this diagram because I think this is really depicting a recent perhaps shift in the field and how we think about MPNs. So I think oftentimes people think about the classical MPNs as different, unique disease entities. And I think in reality, based on research that's been done over the past several years, we're now starting to think about MPNs more as a group of diseases and a spectrum of diseases. So based on some lovely research that's been done, and in part with this diagram, you can see that there's some recent suggestion that there may be a long precursor stage to these diseases as they progress from mutations in the bone marrow, the body's blood factory, to the development of pre-MPN findings, to the development of ET-PV, ultimately to the development of fibrosis, and then on to AML. And you can see there that genetic factors, which we'll talk about, inflammation, which we just mentioned, and then age and comorbidities all contribute to this progression of disease. And so again, as we're thinking about treatments, when to treat, what treatment is right for each individual patient, I think this is an important concept to keep in mind. All right, so I put this in every one of my talks. So every single patient with an MPN has dysregulated signaling through the JAK-STAT signaling pathway. So you see this picture here. Every patient will have dysregulated signaling through this pathway, which leads to increased inflammation, increased inflammatory cytokines, and the disease. And so you can see here, you can get the JAK2 mutation, the calreticulin mutation, and the MPL or MPL mutation, leading to dysregulated signaling. And when you look back to this, now arguably older paper from 2013, looking at the mutational status of patients with PV, ET, and MF, you can see that a majority of patients will have a mutation or a driver mutation in each of the various disease entities. So you see here in PV, a majority of patients have a JAK2 mutation. In ET, again, a large proportion of patients with JAK2, but also a proportion of patients with calreticulin and MPL mutations. And then in primary myelofibrosis, a little bit more heterogeneity with more patients having JAK2 and calreticulin mutations listed there. All right, so this brings me to the first question. Are there different types of mutations in MPNs? Does mutation matter? And the answer is yes. So what we see is two types of mutations, really. So you see on the left there, driver mutations, as we've just talked about. So these are the mutations that develop that drive signaling through that aberrant JAK-STAT signaling pathway. And then we have other somatic mutations. So these are mutations, and that list in the blue bubble there is not conclusive, but these are additional genetic mutations that patients can develop over time. And these matter because they can indicate things such as disease progression or clonal evolution. And they're also impactful as we think about risk assessment for patients and how we make the determination of when to treat patients, who to treat, what we use, et cetera. Okay, so not all mutations are created equal. Not everything is the same. And we see this when we look at driver mutations in terms of survival and thrombosis. So this is a lovely study that broke patients up by mutational status, driver mutational status, into CALR, JAK2, MPL mutation patients, and then triple negative patients. So a small proportion of patients who have no known driver mutation. And you can see that you can actually have different survival based on the type of mutation you have driving disease. And this can also impact the risk of thrombosis. So when we think about patients and how we risk stratify and characterize, we think about what mutations patients have. All right, so I get this question a lot, and this is an important part of my clinic, is how do patients get to a diagnosis of an MPN? So not everybody gets a bone marrow biopsy. And if you take one thing away from this talk today, it would be to keep in mind that I think every single patient should have a bone marrow biopsy as part of the workup for a possible MPN. It's a really important aspect of the diagnosis. It's very helpful for prognostic purposes, and it really confirms what we think based on other findings. So what do we think about when we think about workup? So every patient should get a complete history physical exam. We should be looking for spleen size as enlarged. We should be taking a history about thrombosis, bleeding, and cardiovascular risk. We always do peripheral blood labs. We get a bone marrow biopsy, at least we always do in my clinic. Most folks these days will get molecular testing, so next-gen sequencing testing, and that's helpful when we think about other somatic mutations and risk stratification. And then I think a really key piece to this is an assessment of symptom burden. So that is such an important point and piece of the patient experience. And so as clinicians, we really want to make sure we're evaluating what patients are feeling to help and hopefully make those symptoms better as we think not only about quantity of life, but also overall quality of life. All right, so I'm going to go and break this down by each disease, and then we'll talk a little bit about treatments and clinical trials. So let's think a little bit about ET. So ET is the most common MPN. So it's got the highest incidence and it's got a high disease prevalence, meaning that there are a lot of people living with ET. And why is that? Well, it's because it really is a chronic long-term disease with normal life expectancy. So the more that we make the diagnosis in patients, the more patients there are living with this disease. It tends to be mainly in female patients or has a female predominance. And again, life expectancy is long in this particular patient population. When we think about clinical presentations, a large number of patients are asymptomatic at diagnosis. These patients are found after routine labs are checked, perhaps at a primary care visit. People can present with vasomotor symptoms, and you can see some listed there. So headaches, dizziness, lightheadedness, visual changes. Patients can present with thrombosis, clots, or bleeding. And then in women, recurrent pregnancy loss is always something to think about if there's associated high platelets, because that can be a cause. And if you look at the risk and complications, they're outlined there. So really arterial and venous thromboembolism or clots, bleeding or hemorrhage, and then progression of disease, either to the development of scarring or myelofibrosis and to potentially acute leukemias. All right, so how do we define risk in ET? What are we looking for? And so this question has really been around for many, many years, decades, in fact, and it goes back to the IPSET scoring system. So the International Prognostic Score for ET. There was an initial score system that was developed, and now you'll see that we use the revised IPSET score as the most common diagnostic or prognostic tool for these patients. So in this particular study, 891 patients and 7 international centers were evaluated, and these were equally defined between low risk and high risk ED patients. And you can see that as part of this study, the investigators looked at 4 different factors to help risk stratify patients. So they looked at age, and 60 is the age cutoff that was chosen for this study. It's what we use currently. They looked at cardiovascular risk factors, a previous history of thrombosis, which is predictive of higher risk, and then the JAK2 mutational status. And you can see, based on the survival curves on the right, or the curves on the right for thrombosis-free survival, you can see that if we stratify patients based on the 4 factors listed there, we can actually break people out into 3 different groups and predict how high risk they are for development of various complications such as thrombosis. So, you know, in medicine, we do one thing, and we've done a great job, and we always want to do better. I think that's the overarching goal in medicine. And so you'll see various revised scoring systems and improved scoring systems have evolved. This is the IPSET thrombosis revised scoring system. This looks at history of thrombosis, age, and mutational status, and you can see we actually break people into 4 different risk categories now. So intermediate and high risk disease versus very low risk and low risk disease. And so this is typically what you and your physician or clinician will discuss and decide in clinic as you're thinking about when and if therapy is warranted. Like we talked about before, other somatic mutations or additional mutations in combination with those 3 classic driver mutations are important, and they can be applied again to look at risk. So in ET, this is an example of the mutation enhanced international prognostic scoring system. So this really includes some of the factors that we previously discussed as risk factor, like age and perhaps gender. And then it also adds in these additional mutations when we're trying to identify risk for each individual patient. So lots of progress, lots of applications of novel diagnostics, mainly the NGS sequencing panel. All right, so I'm going to move into PV as the next discussion point, so we keep things moving along here. So PV is the second highest incidence when we think about MPN. So the incidence is about 1.5 to 2.4 cases per 100,000 patient years. Median age of diagnosis per PV is about 60, and there tends to be a male predominance to the development of this disease. Life expectancy here is abnormal, and that's mainly due to the development of complications. And you can see the diagram on the right lists some of the potential complications in patients with PV. These run the gamut from thrombotic or clot complications, the development of secondary malignancies, and then you can see various other problems listed on the right side of the diagram there. Every patient with polycythemia vera, so an overproduction of hemoglobin or red blood cells, has dysregulated iron metabolism. So iron is one of the building blocks for blood. And so you can imagine that in patients who make too much hemoglobin or too much blood, there can be dysregulation of that building block or iron metabolism. And the leading cause of preventable death within this patient population really is thrombosis. And so that's really what we're trying to do as we're treating patients, and one of the primary things we think about. The clinical presentations you see are listed there. Again, patients can be asymptomatic at diagnosis. They can have vasomotor symptoms like we talked about before. And then a common symptom of presentation with PV is actually itching. So people will get itching, which tends to be worse in heat or after a shower. And so those can be some of the things when we think about presentations and think about this for patients. So this is a messy diagram, but I put this up again to highlight the point that patients with PV have dysregulated iron metabolism. And so I've had the incredible fortune of being able to be involved in research looking at the development of novel therapies for patients. And so the iron metabolism pathways, so looking here at things such as hepcidin, have been developed as novel targets for patients and are moved into the realm of clinical trials. And so I think as we learn more about the biology and think more about the biology of these diseases, it allows us to better define and inform our decisions about therapy targets. So I think an important point just to keep in our minds. When we think about risk assessment in PV, we see the conventional risk model, which is listed at the top there. So with PV, we tend to divide patients into low risk versus high risk disease. Again, we use age as an important cut point. So age less than 60 versus age greater than 60. And when patients come to clinic, I always tell them the same thing. The day before your 60th birthday, it's not like you're low risk, and immediately the day after your birthday, you turn into high risk and into a high risk patient. And so there's obviously a little bit of leverage here, but in general, we use 60 as our age point. And then the prior history of thrombosis. So whether or not you've had a previous history of clot. And you can see here, based on those factors, so looking at just age alone and prior history of thrombosis versus not, you see that patients who are younger with no history of thrombosis tend to have improvements in various outcomes, such as cardiovascular event-free survival, thrombosis over survival, in comparison to patients who are either older or patients who have had a previous history of thrombosis. So these are ways, again, that we can risk stratify and think about patients as we're thinking about therapies. And so again, we're going to go back to those mutations that we talked about at the beginning. The mutations matter in PV. They matter in everything, but we'll make the point here. So they matter in PV. And you can use, again, various risk factors. So thrombosis history, age, and then additional adverse mutations. You can see one listed there to really better risk stratify patients. And so I think as we've developed better diagnostics and more diagnostics, such as molecular testing, this has allowed us to really refine and improve on our risk assessments. All right, so let's go to primary myelofibrosis and talk a little bit about this. So this is perhaps the most rare of the MPNs, so incidence of 0.44 per 100,000 per year. Median survival, you can see, ranges from 2.2 to 11 years, which simply tells us that the disease and these diseases are very heterogeneous. And so it really is important to think about the entire patient as we're making decisions and thinking about treatments. Patients can have primary or secondary disease, meaning the disease can develop as its own disease entity. So people come in and are diagnosed with fibrosis, or there are folks who have an antecedent history of either ET or PV who go on to develop fibrosis, and those patients have secondary disease. There's a complex mutational landscape, which we'll talk about. And I think it's important, again, to think about the symptoms. So with myelofibrosis, we think about the biology and the pathophysiology of disease. Patients develop scarring in the body's blood factory, so in the bone marrow. When you can't make blood in bone marrow, you start making blood in other places. The most common place to make blood after a bone marrow is the spleen. And so patients will start to have enlargement of the spleen. This can lead to various symptoms. So early satiety or decreased appetite, weight loss. Patients will develop constitutional symptoms. So again, the itching, the fatigue, the bony pain. And then as the bone marrow develops more scarring and is less able to make blood, we start to see the development of cytopenias. And so I put a diagram down at the bottom, really looking at the differences between proliferative and cytopenic myelofibrosis. And I think this is an important distinction and concept, which has really been developed over the course of the past several years. So there really are two phenotypes of myelofibrosis patients. So patients who have proliferative disease, so normal counts or high counts, these patients tend to generally do better for the reasons listed in that orange colored box. And then there are patients who present with low blood counts. So patients with what we call cytopenic myelofibrosis, so low platelets, anemia. So those patients tend to be higher risk. They tend to have worse outcomes, and they also tend to have fewer treatment options. And so this is an important thing to think about again, as we're considering treatment options and how we're going to manage these patients, because options that are available for some folks may not be available for others. And again, suggests that perhaps there's a different biology between these two different types of disease. All right, so, in MF, there's a lot more in terms of scoring systems. So you can see here several that have been developed over the course of the past 20 years or so, starting on the left and moving to the right. I'm not going to go through all of these, but I put these up just to show that there are various factors listed on the left. So age, leukocytosis or white blood cell count, the symptoms, if you have blasts or immature cells that are circulating in the blood, if you require blood transfusions, depending on your karyotype, meaning what your chromosomes in your bone marrow show or what your mutational statuses are. You can use these various scoring systems, again, to help assess risk. So these are the DIPS and the DIPS Plus scoring systems. These are available in the NCCN guidelines, and these were some of the first scoring systems that were developed for patients, and you can see the various components there. These scoring systems and the DIPS is interesting because it's exactly like it sounds. It's dynamic. So you can restage people over the course of their disease, and you can use this scoring system over time. This is not true of every scoring system. So there are some subtle differences between these. And you can see even between the DIPS and the DIPS Plus, not very creative in names, but that's okay. There's some subtle differences of things that we're looking at in differences. And so these are important scoring systems commonly used, and I think frequently used in the context of clinical trials. So again, we can use mutations. Mutations matter. We've talked about this. And you can actually apply mutational status and karyotype into our scoring systems and risk assessments for patients with MF. And so this is the MIPS 70 version 2. There was a version 1 and version 2. And this breaks patients into 5 different risk categories, ranging from very low risk to very high risk. And you can see based on these various factors and how people are assessed, you can have vast differences when we think about things like overall survival. So I think these are really important concepts and important assessments to be making and thinking about from a patient perspective. These are conversations you're definitely going to want to have with the individual that you're working with for treatment, because depending on the various factors, these may change what you decide to do in terms of management. And I highlight the MySec PM, which is a specific scoring system for patients who have myelofibrosis and a history of ET or PV, so secondary disease. Okay, next questions. Does my MPN need to be treated? Can we use dynamic monitoring? Or what are my best treatment options? So 2 great questions. So I think of treatment for MF in 4 buckets. Okay, so the first conversation I have with patients is generally, and this is mainly applicable to MF, is whether or not stem cell transplant is an option. So that's a dynamic conversation between physicians and providers and patients. Stem cell transplant is the only potentially curative option for MF and MPNs. That being said, it does come with a high risk of morbidity and mortality. And so it's a large conversation that we get started at the beginning of the disease process with most patients. The next bucket is supportive and palliative care. So what adjunctive therapies can we use for patients to make them feel better, to support their hemoglobin, to shrink their spleen if they're having those symptoms related to an enlarged spleen? And that can include things such as transfusions, blood stimulating agents, radiation to the spleen. The next bucket is disease-directed medications. So the most common meds we use that are FDA approved are JAK inhibitors. Those can be used across MPNs, and then medications to cytoreduce or reduce blood counts, such as hydroxyurea or other options, and we'll go through some of those. And then clinical trials, I think, is a really important consideration and something that I really discuss with every single patient that comes to my clinic on a daily basis. All right, so I'm going to run you through the treatment landscapes of what we have available, and then I'm going to just touch very briefly on what's out there, because the conversation about treatment directions of MPNs could be an 8-hour seminar in and of itself with how much is being done. So for ET, dynamic monitoring, one of my favorite things to do. So monitoring patients, making sure things are stable, looking for trends and changes in blood counts. Most patients will get a daily aspirin. This decreases vasomotor symptoms and it prevents those thrombosis complications. And then again, depending on your risk assessment, cytoreductive therapies. So therapies to bring down those high platelet counts, which include hydroxyurea, anagrelide, and then one of my favorites, as many of you know, pegylated interferon. And Meredith's laughing. I do use a lot of pegylated interferon for patients. So when we move to PV, we have a couple more options, okay? So I still use dynamic monitoring. It didn't fit on this slide, but dynamic monitoring in combination with aspirin, again, to decrease your risk of thrombosis and to alleviate those disease-specific symptoms. We use phlebotomy for patients, and that tends to be in lower risk patients. So we take blood out to get them to a goal hematocrit of less than 45. And then you see there, we can use cytoreductive therapies such as hydroxyurea, interferon, and then ruxolitinib or JAK inhibitor in patients who have previously failed another therapy. And then how about myelofibrosis? So again, very similar. You'll see there's a common trend here. A lot of these therapies are the same. So for patients who have a big spleen with MF, we'll use symptom-directed therapies for that. We can use hydroxyurea. We can irradiate the spleen or we can take it out. We treat anemia with transfusions, EPO-stimulating agents, danazol, luspatercept, based on some recent data. We can use JAK inhibitors, and you see the 4 FDA-approved JAK inhibitors listed there. If we go back to the beginning, we remember that every patient with an MPN has dysregulated JAK-STAT signaling, so that's important. Allogeneic stem cell transplant, and then some disease-specific scenarios. And again, I put this slide back up here really to say that there truly is a difference between patients with proliferative and cytopenic myelofibrosis. So those low blood counts versus high blood counts are really important and something we really think about, because those really do impact our treatment options and the options that we have available for patients. Okay. So are there novel agents being developed for patients with MPNs? Yes, absolutely. And it's what makes me excited about getting up and going to work, is all the options that are coming out. But how do you decide, and how do we decide with patients, and how do patients decide what's right for them? So this is just an example, and I won't take you through every disease, but this is the treatment landscape in PV. So this paper was published in March of 2024, so it's 6 months old. And what is remarkable is this table is already out of date. Okay, so we're already moving on. A lot of these studies that say recruiting are now closed. There's new studies that have opened. And so it's truly a remarkable time within this field to be thinking about the treatment landscape. And you can see here, there's so many drugs that are being studied. Some of these drugs are interferons, different formulations of interferons. We're using some of the older drugs in combination. We're using new drugs. So many options. And I highlight, if it's going to pull up, this bar at the top as we think a little bit about clinical trials. So when you as patients are thinking about trials and what's right for you, the things we always talk about are, what's the phase of the trial? We'll talk a bit more about that. What agent is being used? Is it new? Is it old? Is it repurposed? What's going on? How does it work? What's the mode of action? What's the clinical setting? Do patients need to have treatment naive disease, or can they have had previous treatments? What's the patient population that we're looking at? And so these are the considerations as we're talking to patients. And again, this slide I think is incredible. So I think it just shows the amount of progress we've made. So all these drugs are in study. These are all options in clinical trials, but how in the world do you decide? So I get dizzy looking at that. Certainly for patients, that's a huge conversation. So again, lots of therapeutic options. Well, this is specifically for myelofibrosis beyond JAK inhibitors. I'm not going to go through all these. I'm going to talk a little bit more about clinical trials and thinking about questions to ask. But you can see here, we're in an era where we've got FDA-approved JAK inhibitors, we've got novel JAK inhibitors, we've got novel combinations, and we've got novel drugs with novel mechanisms. So, so many options, so many things coming up the pipeline. So I'm going to spend the next just 5 minutes here or so talking a little bit about clinical trials, because this is a component of care that's near and dear to my heart, something I have a privilege of being a part of, and something, again, that is so important within the MPN community, because all of the progress that's been made in recent years really has come from trials and the work that's preclinically gone into the development of these. So from a patient perspective, as you're thinking about clinical trials, when you're in clinic and this conversation comes up, what should you be thinking about? What questions should you ask? And so I wanted to bring up a few things to think about. So number one is, what phase of trial are you being offered? What phase is this drug in? So a lot of patients, have lots of questions about the study phases, how this works. So preclinical data does not involve patients, right? So in preclinical data, where these drugs are really developed, we're looking at animal models of disease. And it's not until drugs hit the phase 1 stage do they go into humans. So phase 1 studies are really early phase studies. These novel compounds can be tested in either healthy volunteers or in a small subset of patients. And the goal in a phase 1 study is really to determine if the medication is safe and tolerable, okay? So there's a lot of advantages for phase 1 studies. In a majority of studies, every patient gets the study drug, as opposed to studies later in development, which would tend to be randomized studies. So there's certainly risks and benefits, but they are earlier in development. After phase 1 studies, novel compounds move into phase 2 of testing, which tests drugs on larger groups and really starts to look at efficacy in addition to safety. And then we have phase 3 studies, which are these larger studies, again, looking now mainly for efficacy and safety. And a lot of these studies are randomized, meaning that patients will either get placebo or a best available therapy in comparison to the therapy drug in question. And so these are just some important considerations. What do you want to think about when you're sitting in the clinic? So what's the phase of the trial? Are there other treatment options? So if you're at the point where you're talking about trial, what else are your options? What else can you consider? I always tell patients when we talk about the results of past studies. So if a drug is in phase 3, I always like to talk about the phase 1 or phase 2 results. So can we get an idea of if the compound is safe or effective? One thing I always discuss with patients is, are there procedures or tests that are going to be required for participation? So do you need a bone marrow biopsy? Do you need a CT scan? What goes into you participating in this study? Of course, we always talk about potential side effects. An important question is to ask about the time commitment, how often you're coming to clinic, how often you're going to be there. It can be a long day depending on how drugs are administered. Is there travel associated? Is there cost coverage for travel? Are there resources for that? And then how long do the trials run? So is there an endpoint to the study? Does it go for a year and then patients need to find another option? Or is the sponsor of this particular study going to provide the study drug for a longer duration of time? So I think these are really important considerations as you're thinking about whether trials are right for you. And then the other question is, what does the process look like? So, what I always tell people is consider and learn about every single treatment option. So learn about what's available off study, what's available on study. Ask about different studies. There's, at most places we have more than one, or a lot of times there's many institutions in one city or in close proximity. So are there other study options close by? You always want to meet your team. And so as part of the clinical trials team, we have several individuals involved. So there's myself, there's usually an advanced practice provider. We have wonderful pharmacists, like the one on this call, who are very helpful, and investigational pharmacists. We have research coordinators, we have data coordinators, we have regulatory coordinators. So you really want to know who you're working with. You want to take a lot of time and read the consent forms and make sure that you ask all questions and really feel like you know what goes into the study. Once patients have signed consent, we think about whether or not they meet specific criteria to enroll on the study. And as part of that, patients typically get several testing procedures done. And then after folks are eligible to start on study, there really is an entire schedule of assessments. And so I think that's really important for patients to ask up front and to continue to ask about as they move through the trials and the clinical trials process. So I'm going to give you a few summary thoughts and then move on to the other presenters to add some information. And then we'll obviously take questions at the end. So the future really is bright for all patients with MPNs. I find myself so fortunate to be a part of the field at this time because, you know, when I go back to 10 years ago, when I first started doing this, the treatment options were limited and we didn't have a lot of options for patients. And so we really have made as a field significant progress, and there's just so much more to come. I make the point that the more we understand the biology of these diseases, so whether inflammation is driving them, genetic problems are driving them, what's driving the diseases, the better equipped you are to develop therapies. And so that's how we move the field forward. From a patient perspective, we always encourage folks to ask questions. All questions are good questions. The more you ask, the better. Our job in clinic is to have these conversations and make sure that you feel informed and are making the best decision for you. And then again, within the MPN space, there are so many clinical trials now, so many options that we always encourage folks to encourage those if they're able to. And so I'm going to stop there, say thank you to the NCCN for the panelists, and then I think most importantly to the patients, because you really are the reason that we do this.
All right, thank you very much, Lindsay, and thank you to NCCN for the opportunity. My name is Meredith Mormon. I am a clinical pharmacist in our outpatient leukemia and lymphoma clinic, and I have the pleasure of working with Dr. Ryan regularly. She's in clinic a little bit more often than she has been historically, so I get to see a lot of her these days. So I'm going to specifically talk about the role of the pharmacist in treatment of patients with MPNs. And so from my perspective, the primary roles for the clinical pharmacists are multi-pronged. So providing education, reviewing for drug interactions, looking at medication dose adjustments, supportive care, and something that I think is becoming increasingly important or increasingly part of this role is medication access and regulatory compliance. And then a necessary evil, I would say, prior authorization and patient assistance is really a very important part of the role of pharmacists and pharmacy technicians as well. So I'll talk a little bit more in detail about each of these. This is sort of broad strokes about things that I do to help this population of patients. And so one of my favorite tasks, one of my favorite job responsibilities is getting to sit down face to face with patients and providing education about a new therapy that they're going to start. And so I think one of the things that I have learned, this really is most successful if there are multiple opportunities along the treatment trajectory to interface with the patient, to interface with family members. I think often at the time of diagnosis or when you're first meeting us in clinic, there's a lot of overwhelm. There's a lot of testing that goes on, a lot of things that you need to be checking off your to-do list. And so I think with repeated interaction, that education component is best utilized. I also do think, you know, as we get to the point, if we get to the point that you're starting a new therapy, I certainly talk to you about what the different toxicities and side effects are. There is often a discrepancy in what's most important to us on the healthcare provider side versus what's most important or most impactful to your quality of life on the patient side. And so that is something that I've learned over the course of my career. And every now and then there's a certain patient case that sort of reinforces that point for me very directly. I do think treatment schedules is another piece of the education process. It really depends. Sometimes it's fairly simple. You know, we're going to give you an oral medication that you can take at home. It's once a day, limited side effects. So that's sort of perhaps best case scenario, but there often are a combination of drugs. Perhaps some are oral, some are IV. perhaps you're on a clinical trial, and that certainly, I would say, in most situations can increase the complexity of your visits, what things are going to look like. The other piece is supportive care medications and where they factor into the equation, and timing of those with, disease-directed therapies. And then I think the other thing that often, at least during initial visits when patients are first presenting and first establishing with us, is the duration of treatment, whether these are indefinite or finite treatments. And I would say in most cases in this particular realm of diseases, most of the treatments are indefinite, assuming that you are responding and tolerating the drug. Obviously, there's some conversations that might come to light if one of those, you're not responding or you're not tolerating it. But I do think that that can become an important piece to make sure that the patient understands. The other part of it is education of other healthcare providers. So a lot of these drugs that we use for management of MPNs are oral, and so our nursing staff in the treatment areas in our clinics might not be that familiar, but they may see these patients periodically. So trying to help make sure that other clinical staff have an understanding of what these therapies look like, what side effects we should be expecting, can also be an important part of my role. One of the big things, the vast majority of these drugs in current state are oral drugs. And so because of that, and they're generally what we call small molecule inhibitors, they tend to be prone to drug interactions with some other therapies that patients would be taking for either some sort of cardiac comorbidity, potentially high cholesterol. So that is one of the big roles that I will do with each patient. If Lindsay comes to me and says, I want to start this patient on drug X, then I will review their medication profile and just look for any interactions. Sometimes, depending on the specific patient, they are on other supportive care medications like antifungals or potentially antibiotics. And so there are certain drug classes that tend to be more problematic, but generally we're able to compensate for that drug interaction appropriately so that we can continue MPN-directed therapy or initiate MPN-directed therapy while maintaining those other maintenance medications for our patient. There are certain foods, potentially, grapefruit, to be honest, is the big offender most of the time. And so some other diet things that we might need to discuss with patients that can alter or impact the clearance of some of these drugs. And then we do have a lot of patients who have questions about different herbal products or supplements. And so my recommendation to patients is generally, if you want to consider some sort of herbal product or supplement, please, please, please check with us before you even buy it. Because, there is definitely generally less regulation with herbal products and supplements, but there again are certain supplements that can be prone to interaction. And so we'd rather you check with us first than spend money that you can't potentially get back. The other big part, and some of this is just reviewing, are we providing or are we thinking about starting the patient on the right dose of medication? So one of the things that I will help Lindsay with, she generally does a pretty stellar job of this on her own, but making sure that we have all the necessary diagnostic tests prior to starting a patient on chemotherapy or an oral agent. And so some of the drugs, we have to check your heart function and look at an EKG. Some of the drugs, there are some sort of one-off labs that we may not check across the board. So making sure that patients have all those baseline testing. In addition to some of the other standard tests that we do. So checking liver function and kidney function, because often a lot of these therapies will have dose recommendations for patients that have abnormal liver or kidney function. And then some of our drugs do have approvals in specific niches of patients based on their blood counts. And so making sure that we're providing patients with the appropriate dose based on a platelet count is a situation that I run into pretty regularly. This is less an issue with a lot of the oral drugs for MPNs, but in some situations, patients might be approaching a lifetime dose, or we're limited on the amount of drug that we can give someone. So just being aware of those situations where they exist and then monitoring the lifetime dose of a patient also becomes important. And then this is a population of patients where supportive care, I think, is particularly important and can honestly go a long way in helping manage a patient's disease. So we're obviously very fortunate to have organizations such as NCCN that provide both disease state management guidelines as well as supportive care. So one of the big things that we run into with this class of drugs that we use for MPNs is some trouble with nausea and vomiting. So making sure that patients have appropriate antiemetics or anti-nausea medication, making sure that they understand how to use those, when to take them, what to expect. Certain populations of patients with MPNs certainly are at risk for infection based on their blood counts. So making sure that we're assessing that risk appropriately and then providing appropriate antibiotic or antifungal prophylaxis in that population. And then it's an infrequent situation for patients with MPNs, but assessing for patients that might be at risk for tumor lysis syndrome. So if tumor lysis happens, this tends to be a much more urgent situation or what we call an oncologic emergency. So again, making sure that we are providing prophylaxis and ideally preventing this particular situation. But if we're not able to accomplish that, then making sure that we interact, that we intervene rapidly and get that particular situation under control. Medication access has become more and more a part of my role. So a lot of these drugs, so MPNs in general, are pretty uncommon. Working at a place like Duke or where Ruth receives care, you might think that they're more common than they actually are. But it's ultimately a very small population of patients. And so because of that, as new drugs have become available, sometimes they are limited distribution. So figuring out, can we get access to the drug through, our retail pharmacies, or do we have to use a specific outside specialty pharmacy? And then the more important piece, I think, for patients, often thinking about or reading about or understanding the cost of most of these medications, which are oral, can be extremely daunting and extremely cumbersome. I'm very fortunate to have patient assistance technicians, so pharmacy technician staff that work with me on this piece of things. So generally, we have to get approval through a patient's insurance to use these drugs. So they assist with that process. And then once we have that piece in place, we can figure out what the out-of-pocket expectation is for the patient. Our goal is always that the patient will ideally pay nothing. So there's a couple different processes that we navigate to ideally get to that point. Some of that is determined by your insurance. And so given that this is generally, these MPNs are generally diseases that happen in patients, over the age of 60, where patients are transitioning from private health insurance to potentially Medicare, that changes this conversation and can make the out-of-pocket cost for patients much more significant. So this is something that I do on a daily basis, but our goal is really that you pay as little as possible, and we'll help you figure out the pieces to get that funding in place. And then the last piece, and again, I would say in this particular population of patients, this is becoming more prominent. Clinical trials, as Dr. Ryan has mentioned, are much more significant and are really sort of up and coming and helping us figure out what the next treatment options are. So some of the role of a pharmacist in that is just making sure that we've built the treatment plan so that the physicians and the research staff can follow the treatment plan and we're ordering drug appropriately. Again, reviewing medications to screen for drug interactions. And then there are different dispensing systems and different paperwork and audit trails that need to be followed for patients on clinical trials to make sure that we're maintaining our drug inventory appropriately. We're dispensing the drug to patients based on appropriate parameters. So pharmacists are involved in all pieces of that process. The other thing that I would say is fairly new, not necessarily specific to drugs to treat MPNs, but there have been what we call REMS programs, risk evaluation and mitigation strategy programs, that have become more prominent with new drugs as they're approved by the FDA. And so the FDA has approved the drug, but they do recognize that there are certain side effects and toxicity. And so these are different strategies to minimize those toxicities or ensure that we're monitoring appropriately. And so those programs can be widely variable as far as their complexity. So sometimes it's just a matter of a provider being educated on the product and then agreeing that they will also educate the patient on the product. Sometimes there are much more complex. So a patient has to be enrolled, a provider has to be enrolled, a pharmacy has to be enrolled. The provider has to get a code, the pharmacy has to get a code. So it can really vary in complexity from drug to drug, but there are enough of them that we have a specific group of pharmacists that is monitoring our participation in those, making sure that our providers and our pharmacies are doing what we need to be doing to ensure safe use of the drugs. And so with that, I will pass things on to Ruth, who will be the last presenter for today.
Thank you so much. Thanks to both of you, the first two presenters who left us with all kinds of important information. So my name is Ruth Fine-Ravel. I'm a patient advocate. I'm also someone who has lived with an MPN of one kind or another for 30 years. It started with ET, became PV, and now myelofibrosis. So that's the perspective I bring. I'm also a health and science writer, and I've become a patient advocate. So let me move along here. And thank you to the NCCN, I should add, for holding this webinar and being very dedicated not only to clinician education, but to patient education. I'm very privileged to sit on the NCCN panel for MPNs. So they're very true to their word about having patient impact, which we need to all appreciate. So we've all heard this, right? But you look fine. MPNs are a chronic condition, and we look fine, most of us, most of the time, not necessarily when we can't get out of the recliner on some days when the fatigue is just overwhelming, but for the most part, we look fine. So our friends and family don't know why it is that we turn down social engagements. They don't understand why we look fine, but we keep talking about having this chronic cancer or chronic disorder. They think about acute cancers, and we know that MPNs are classified as a chronic blood cancer, though everybody doesn't refer to them that way. They are technically a cancer. So the people around us don't understand. So I'd like to flip that and put some of that back on us. So it brings us back around to the importance of understanding our own diagnosis and condition, and understanding it well enough that you could explain it to your 10-year-old child, grandchild, child down the street, niece, nephew, whoever that may be. So first, I think we need to really understand our own diagnosis and condition so that we can explain it to others. Then it's on us to tell our family and friends not only what condition this is and try to educate them so they understand better, but also to explain to them how we're feeling some days, how we may feel and how that may change, and how they may not understand because one day, maybe 3 months in a row, we show up feeling fine and looking fine, and then one day we just don't show up to our 2-year-old grandchild's birthday party, and people don't understand why. So again, that's on us. We need to explain it to people in our lives, because otherwise we can't expect them to understand. The third thing is, remember that your doctor isn't a mind reader either. So if we don't share with our doctors and PAs and nurse practitioners, whether it's in a primary care setting or a community oncology hematology setting, or a specialist setting in a major academic center, in any of those situations, we need to share how we feel, and we need to share with them how those symptoms might change. Here's the camel. So you are not a camel. I put this slide up there. I took this photograph 2 years ago when I was at an MPN, a global MPN patient advocates meeting. And I was walking down to the Dead Sea, as you do in Israel, and there's this camel on the side of the road, right? And this camel is chomping away at this grass. And let me get close enough to take this photograph. It was amazing, right? So then I go on my way, and I'm go down to the border, and we do what you do at the Dead Sea. You float around, you put mud all over your body, you do relax, have a snack. 2.5 hours later, I walk back up the same hill, and there's that same camel, and he's in the exact same position, eating the exact same grass. And it hit me that camels are so predictable. He was in the same place doing the same thing for 2.5 hours. And it hit me how MPN patients are anything but predictable. So I want to speak to you about that a little bit. You are you. You aren't a camel. Every person living with an MPN is different. Remember to talk about what you feel and what you experience when you meet your clinicians, and again with family and friends, because every patient is different. And what you experience isn't the same as any other patient, even though they may have had the disease for the same amount of time, they may have the same blood work. So these are rare conditions. So remember that your doctors and care teams don't see patients as regularly as more common diseases. So you can't expect them to know the full range of the differences that you may experience or we may experience as a patient group. Part of that is to notice changes and communicate them. Now, sometimes it's hard. A doctor may ask you an open-ended question. So how do you feel? Do you notice any changes? That's very difficult to answer because we don't sit there all day long and take notes about how we feel, right? So I know for myself, for many years, I would just go to the doctor's office for my regular visits and say, oh, I feel great. I feel fine. And I would forget about all those days that I didn't feel fine, all the days that I had headaches or visual blind spots where, again, I'm a writer, so I'm on my computer all day. And there was a part of my vision that couldn't see for a couple of hours. Bone pain that was pushed off as probably arthritis, but it wasn't arthritis. I would say, no, this isn't my joints. This is my bones that hurt. And so it's, again, on us to keep track of these changes. There are symptom assessment forms, which were referred to earlier, and they help us. They help us remember what we're experiencing and what those changes may be. And if you still can't remember and you think that you're fine, think about your last birthday. On my last birthday, are there things I could do then that I can't do now? Last summer, are there things I could ride my bike for 15 miles, but I couldn't do that today? Those are important things and are important ways to remember that your body has changed. So we talk a lot about patient advocacy, and I started this in my introduction by saying I'm a patient advocate, but what does that really look like, right? So first of all, it's important to question everything about your treatment plan until you fully understand it. That's the very first 101 in my mind about self-advocacy. We talked about knowing what your disorder is, knowing everything you can about the disease, knowing what the expectations are, as well as what's on paper that you might be prone to. So question everything. When it comes to your treatment plan, there are so many options. As was referred to earlier, this is such a hopeful time for MPNs. So many options that weren't there 10 years ago, certainly not 30 years ago when I was first diagnosed, or even 5 years ago. So question everything. Ask about all of your treatment options, and specifically, why is this one best for you now? Right? So a lot of us go through a watch and wait period. Why is that best for me now? Is there not something that perhaps you could do to improve my symptoms? There's the question of, are we learning through research? Have we learned through research in the last 2 or 3 years, perhaps, that maybe earlier intervention could have some benefits? These are questions to ask your doctor. And again, depending on what setting you're seeing a doctor in, most people, in fact, with MPNs, see physicians in a community care setting. If you're seeing a local hematology oncologist, chances are they don't see a lot of patients with what you have. If you're fortunate enough, like I am, though I didn't always, I now see a physician, a care team at a major medical center in New York. That's very different than seeing somebody in a community setting, and they may not be aware of these changes that have happened in thinking. These changes in thinking just over the last 2 to 3 years. They may know that, okay, this is what we do with MPNs. We watch and wait until something terrible happens, like a blood clot, which is what happened to me. And it was never about prevention. It was about, okay, when something when a crisis happens, we deal with it. And we want to get ahead of that, obviously. Another thing about advocating for yourself is if you are in a community setting, seeing a community hematology oncologist, get a second opinion or a third opinion. Consult with an MPN specialist. We're so fortunate to have people who are what I call the super specialists now. And again, that's evolved over the last 10 years because we have more options and because what we've learned about these disorders. It doesn't mean you can't see your community physician on a regular basis. You can get a consult with an MPN specialist. I don't know any MPN specialist who won't meet you in that place, whether it's virtually or in person. And then if you don't want to change your care for them to be your primary care specialist for your MPN, in most cases, they will consult with your primary care or with your MPN specialist or with your hematology oncology specialist in your community setting. So you then get the benefit of a consult between a specialist and a super specialist. And that helps bring the knowledge that we have in our major medical centers, major academic centers, what's happening in the research labs, down to the level of the setting in your backyard. And we know that everybody isn't privileged enough, isn't fortunate enough to travel to a major medical center. I travel 3.5 hours each way every 3 to 6 weeks because I'm in a clinical trial, which I'll get to after. And everyone isn't in that situation. It's expensive. It takes time away from work. If you have childcare issues, if you have transportation issues. So we know that's a privilege that everyone doesn't have the ability to take advantage of. So try a consult with an MPN specialist and know that that's another option. Another thing on my advocacy list is know your care team's expectations and how they may change. This is a question, again, that's on us as patients. Clinicians may have a very clear understanding of what their expectations are. They don't always share that unless we ask. It's not intentional. They're not keeping it from us, but it's not necessarily a part of that 15-minute consult with your doctor. What are their expectations? How can that help you with the uncertainty of these diseases? Because we know the uncertainties can be palpable. The uncertainties are overwhelming. We don't know if our ET might progress to PV, might progress to MF, or in the very rare instance, might progress to acute leukemia. So that's always in our minds. Let's hope it's not always there, but it is on our minds. And what are the expectations of our care team? What are they looking for that might be an indication that, nope, don't worry about progression right now. You're doing well. And these things that we look for, we're not seeing with you, or vice versa. We're seeing this and this and this, which will keep our radars up to keep us and you informed about your risks risk for progression and risks for complications. So what are their expectations? And you need to start that conversation. Unfortunately or fortunately, you have the right to start that conversation. I think the most underused word that we should all have as our most often used word is why. So again, we sit as a patient or a care partner in our doctor's offices, and we listen really well. I think we don't ask why enough. Why are you recommending this particular treatment? Why are you not recommending this? Why are we waiting if there might be something that's earlier intervention? Why are you not concerned that this is a symptom that I'm concerned about? Why do you not think this particular symptom that I'm having is not related to my MPN when I believe that it is? It just feels like it is. I didn't have it before, or I've spoken to lots of other people who have an MPN who have similar symptoms. So that question, why, I think is a big advocacy question. It's also okay to say no. You have the right to say no. The why question should come first. Why this, why that, and then make an educated decision. And it's okay to say no. And it's okay to say, I don't understand. Please explain that differently. Please explain that again. Sometimes by talking to different people, one a physician, one a caretaker, or one a PA, sometimes a social worker, you can hear things differently. We all hear things differently, and we all learn things differently. Ask to have someone else explain something, or get a second opinion where someone might explain something differently to you. And then again, it's okay to say, no, I don't want to make that choice. I want to wait because I'm not symptomatic. I want to wait before I start active treatment. Or I don't like the sounds of that particular treatment. What other options do I have? And what's down the what's in the pipeline in the way of clinical trials that maybe your clinician isn't thinking to speak to you about? Bottom line is ask for what you need, and that's what advocacy is all about. Your rights and opportunities. So you do have a choice who to tell about your diagnosis. This comes back to the first subject I was talking about, how we can't expect people to understand what we're going through and how we feel if we don't tell them. However, there's a social pressure sometimes for people with cancer or any kind of chronic disease to tell everyone they know, and many people don't want that situation. I know for me, I didn't tell people for decades. I'm not saying that's right. I've learned over time that that was not helpful to me. And it was not helpful to other people that I care about. But we have the opportunity to make our choices, right? If you want to stand on your roof or in your on your Facebook page and scream to everyone, I've been diagnosed with an MPN and this is what it means, and I'm terrified, or I'm not concerned at all because of A, B, and C. You have the right, absolutely, you have the right to tell everyone you come in contact with. Maybe it makes you feel better. Maybe it makes you feel that people will understand you better. But likewise, you have that right to keep it very private and to keep it to yourself and those very close to you. The important part of that is that if that's your choice, that you don't really want it to take over your life in every conversation, your personal conversations, your social settings, then make sure you tell the people in your life, your loved ones, your friends, that, you know, I'm confiding in you, but I'd prefer that it's not common knowledge. And that's something that I think people don't think a lot about. So you have the opportunity to advocate for yourself. You have the opportunity to choose who knows about your health condition, and you have the opportunity to keep it a little tighter, who knows and who doesn't. This is a big one for me as an advocate. You have the right to feel comfortable. I think comfort is underestimated. And comfort is both physical and emotional. You will find, in my experience and the people I speak to, other patients and caregivers, you'll find that your care team mostly talks about the physical comfort involved in MPNs or any disease. There's specifically for MPNs, because of the uncertainties, because of the emotional stress of those uncertainties, and the anxiety that keeps us from sleeping at night, the anxieties that keep us, the anxiety that comes from that uncertainty, there's an emotional stress, and we have the right to feel a little bit more comfortable with that and get help in that regard. So explore treatments and alternate therapies that improve how you feel, but make sure that that includes stress reduction. It may take asking for a consult with a social worker or a psychologist or a psychiatrist. Again, at a major academic center, more than your community oncology setting, the MPN specialists, at least that I come in contact, are very aware of the emotional and anxiety component to MPNs, and they are more likely to invite you to have an outside consultant. But that doesn't mean that that's always going to be the case. Bring it up. You know, if I'm feeling a little bit unsettled, if I'm feeling a lot of stress, see who can help you, who on that care team can help you. Get a second or third opinion until you feel comfortable. If you come into contact with a physician who tries to talk you out of a second opinion, my advice is find another physician. I don't know any good physicians, particularly in the MPN world, who don't value another set of eyes and another set of ears. I think it's really important to feel comfortable asking for a second opinion and a third opinion if you need to, because again, it's a rare disease and group of diseases, and every patient is different, and you need to feel comfortable moving forward. So just a little bit more from me. Advocacy is in your head. And what do I mean by that? Getting comfortable advocating for yourself may take practice. You have to get it out of your head. It's in your head that you may not have the right to ask questions. You may not feel comfortable asking questions. It's easy to get distracted in a doctor's office listening and then forget to ask all of your questions, or feel that, okay, I've been here, I now have taken up enough of this doctor's time and I don't really have time to ask all of my questions. Remind yourself at that point, go back to your head, to the voice in your head, that I have the right to feel comfortable that all my questions are answered, and I have the right to healthcare that meets my needs. Remind yourself it's your health, it's your life. And remember that no question is silly, right? No question is silly. We all learn differently, hear differently, and until we fully understand every question, there's no foolish question, only good answers. And remember that you have a right to know, and that goes to a right to know everything. So my final slide, this is a picture of my son and myself and my son dancing at his wedding. And I put this up there because I am one of the lucky ones, and I don't ever take that for granted any day of my life. So when I first told my MPN story for the very first time, it was in front of a panel to educate the FDA about MPNs. And I went through my story very unemotionally. And at the very end, my voice cracked. My son had just gotten engaged, and I had just weeks before been diagnosed with myelofibrosis. And I remember my voice cracking as I said, I just want to be able to dance at my son's wedding. Well, with COVID postponements and me going on a clinical trial and feeling incredibly well, I did in fact dance at my son's wedding. So the points I wanted to make here about being one of the lucky ones, this happened because of a shared decision model that, again, I'm very fortunate to have had at this major medical center, but it's also because I advocated for myself. So there's a benefit from the power of shared decision-making. And what does that look like? That means that you have a physician and a care team who's willing to lay out options, discuss, as we talked about, discuss how you feel, how your symptoms may have changed, what your concerns are, what their expectations are, so that you understand what your expectations might be. And then have that decision-making be mutual. So options are laid out for you. You ask your questions so you understand what all of your options are. And then you make this decision together. Your healthcare team, your specialist may suggest their recommendation. This is by far my recommendation, my highest recommendation, but you may ask why. And it's good for you to understand that. That's true shared decision-making. And again, I benefited from that, and I still do. Work with your specialist as part of your primary care team. Again, very privileged. My super MPN specialist really acts like part of my primary care team. She wants to know if I go to an urgent care. She wants to know if I have dental work. She wants to know if I'm put on any medication so that she can, be sure that there are no interactions or things to watch for side effects. So she's very much not over here in this tunnel while my primary care is over here, 300 miles away. She becomes a part of my primary care team. And that model is becoming more and more popular, but it's very time consuming. And I think as advocates and patients, we have to play a role in making sure that that happens, encouraging that. Ask about clinical trials that may be appropriate. I've been in a clinical trial for 5.5 years. I would not have perhaps I would not have been able to dance at my son's wedding, certainly not on my toes twirling. I couldn't walk up the street without holding on to a lamppost. So the clinical trial has changed my life. And in a lot of settings, people aren't asked about clinical trials. First of all, they aren't asked if they're interested in exploring clinical trials. Again, that happens more at major medical centers. That's where consults come in again. At a consult at a major, but with a major specialist, you will hear more, especially if you ask about clinical trials, and they can bring those opportunities back to your community oncologist, if that's who you're seeing, and see if that there's something that fits well with your situation. One of the things I like to tell other patients is that you are you who happens to have a chronic blood cancer. You happen to have an MPN. Don't let, if you can help it, and do everything in your power to not become that condition. You are you. You have a chronic condition. Yes, there's anxiety. Yes, there's things you have to do to make yourself feel better. Hopefully you will find treatments that work for you. But this is a long haul group of diseases. Try to be you. Try to be on top of who you are and how you can make yourself feel better, and get the help that you need, and dance every chance you can. And thank you for the time.
Thank you to all our presenters. You gave us a lot of good information, lots to think about. We've come to the end of our presentations, and now we're going to spend a few minutes going over some questions that have been presented. And I'm going to hand it over to Dr. Ryan.
All right, so I'm going to read the questions out loud. If there's more, feel free to add them to the Q&A. So the first question here is it unusual for my hematologist to not see me or do blood work for 6 months? I am 68, have ET, JAK2 positive, on hydroxyurea 5 days per week. So I would say, just from my practice, and Meredith knows me and my practice as well, I think this is pretty common. If we have folks who are stable on the current therapy that they're on, so current cytoreductive, haven't had recent changes in blood counts, oftentimes we will see folks every 6 months. I usually tell folks that if there's a major change, patients are usually the first to know about it because symptoms will change. So I think every 3 to 6 months is a reasonable monitoring plan for a lot of patients. I don't know if anybody else wanted to comment. All right, let's go to the next question, which I think is a phenomenal question. So I have recently been confused as to whether inflammation creates the mutations, JAK2 methylcalreticulin, or whether the mutation causes the inflammation, chicken versus egg question. I think if we knew the answer to that question, it is so important, we'd be done as a field of research. So I don't know. And I don't know that we'll ever definitively know what comes first. But I think they are definitely a coexisting relationship that, and I think they're definitely both a huge part of the biology. That's a phenomenal question, though. The next question was, I think, a great question for Ruth for this one. So should I worry if my doctor says ET is not as bad as diabetes or rheumatoid arthritis, and that if this is all he did in his practice, he would be so bored?
Did you want me to answer that? Right.
So, yeah, well, I think,
yeah. I mean, the bottom line is that to you, to a patient, it's easy to feel invisible to begin with. So if you are seeing a doctor who thinks what you have is not a big deal, that's problematic. If they equate it to another chronic disease to give you a sense of comfort, that it's a long-term, it's a lifelong chronic condition, that analogy is probably useful.
Yeah, so I'd agree with that. I think, absolutely. All right, the next question. Can PV be caused by a biologic for rheumatoid arthritis? Meredith, do you have any comment on that one?
I mean, I don't know the data off the top of my head. I'm guessing that probably something has been reported somewhere. But I think you could say that about most questions like that. I don't know. I mean, that's probably not the best answer, but it's
I would
probably
give
been
the same one.
reported.
So that would be my, so it's probably been reported, but that probably small, but generally, I think in general, MPNs, not the direct cause of medication effect. All right, the next question, another really good one. Do you feel that VAF is a valid biomarker for MPN disease status? I love that question. So I'm going to take this one because I'm excited about it. So, I think when we think about biomarkers and endpoints for clinical trials, in the MPN community, we have generally used total symptom score. So how much better do patients feel, and spleen volume reduction as our markers of success. And that's been our standard. I think, again, as we've learned more about the biology of the disease, and as we've had more development of NGS panels and molecular studies, that's become more interesting from a biomarker perspective. So there's a lot of research right now looking at VAFs, how they correlate to patients in terms of disease response, disease assessments. And so I think this is a really up and coming consideration. I don't know that we have a huge data set yet to determine if it's going to be a valid biomarker, but I think I personally am hopeful that as we gain more insight, that will be something that we can use to follow patients over time, independent of spleen and symptoms, which is what we typically will do now.
I want to put my patient advocate hat on for a second. So for those who don't know, VAF is a variable allele frequency. And what that means is the amount, please correct me if I'm wrong, the amount of mutated MPN cells. So correct me if I'm wrong on that, but people don't always know what that is.
Right. So, looking at the allele frequency within of that particular mutation. Absolutely. Yeah. All right. Next question. Is this a poor prognosis if my ET progresses? So, again, if I think back to some of the initial slides we put up, I really do think that as we've learned more about MPNs, we've begun to think about them more as a spectrum of disease. So I think of this from a couple of perspectives. So number one, the longer that patients are living, the longer a period of time they have for that disease to progress. So the fact that we've got people living so long and longer inherently increases the risk, because people are doing so well for such a long period of time. I do think that MPNs exist on a spectrum. And so I think if people live long enough, eventually folks will potentially progress. And so I think a lot of factors go into this in terms of how fast this happens. Are there higher risk mutations? And so I think that's where some of those scoring systems are really helpful in figuring that out as people move through the process. So, as physicians, we never want to see things progress and change, and they do. And I think a large part of things can sometimes be looking at trends and trajectory. The next question, how common is the overlap of MPN and MDS, and are they usually treated separately? So another phenomenal question, going back to the biology of the disease. So sometimes patients have MPNs, bone marrow overproduction problems. Sometimes they have dysplastic syndromes, meaning that their bone marrow is producing dysplastic or odd-looking cells. And sometimes those diseases converge and can create another disease entity where people have a combination of both or components of each. So I will say that those tend to be a different group of diseases and are managed, I would say, differently than patients, as we've talked about today, with more of the classical MPNs.
I think, was that the last one?
I think there was one more. I'll read the last one. So I have MF. I've had MF for 6 years, and my hematologist said he thought my spleen was enlarging when I met with him 2 weeks ago when he palpated. Would it be a good idea to get a more definitive measure, such as an ultrasound, to determine the actual size of my spleen? So I'm going to ask Ruth, how often, in your experience, I don't think there's a right answer for this, but how often do you get imaging?
Well, That's a loaded question because I'm not the average patient, right? Because I'm in a clinical trial. So clinical trials, for those who don't know, come with protocols that are very, very specific, agreed upon with the FDA when a clinical trial becomes active. So part of the protocol for my trial, I have blood work every 3 weeks. Every 6 weeks, I see the physician team, my care team, at which time they do not just blood work, but also imaging and a bone marrow biopsy initially for the first 3 years. I think it was every at least twice a year, maybe 3 times a year, and then twice a year, and now annually. So I think that it really depends. I think in my experience, when I wasn't in a clinical trial, if my spleen was feeling more enlarged than the time before, what we call palpated, right? The doctor could feel the spleen, then I would be sent for imaging to see how much that had changed.
Yeah, I think clinically we often, if there's some concern that the disease is changing, right? So blood counts are changing, spleen is enlarging. I think that's the time point at which you want to get those additional diagnostics to think about whether or not things are starting to change. Do we have time for
also, I
one more
think,
question?
sorry, if I can jump in, I also think it has to do with if you begin a new treatment, and I would think you would agree with this, right? Anytime that you start a new treatment, a new drug of any kind, they're going to watch your spleen more carefully, and so sometimes there's imaging more often then because they want to be more concise about the reduction of your spleen.
We're out of time for today. We want to thank all the presenters and thank you all for attending. The NCCN Foundation would also like to thank the corporate supporter of this webinar.